Testing 1 2 1 2 1 2. Test 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 test.
afternoon, everyone. My name is Lacey Pullen. I'm an outcomes manager here at St. Vincent's East, and I kind of help the physicians and oversee sepsis and how we're doing with that. So we're going to talk a little bit about sepsis before Dr. Middlebrooks gets started. I would like to disclose that I have no financial disclosures, and on the screen you can see my contact information. We're also, Debbie Wisnut is my administrative director for the system, and we work really closely throughout the whole system. And then here at St. Vincent's East, we actually have a sepsis team that is chaired by Dr. Middlebrooks. It's multidisciplinary, has MDs, NPs, nursing. We have our nurse educators as well, different unit managers, and our team meets monthly. So sepsis is the leading cause of mortality in hospitals, and our treatment is geared toward early recognition, so we can give these patients early treatment to better save their lives. The core measure bundle was introduced by CMS in October of 2015. It promotes guidelines for early recognition and treatment within the first 3 hours and the first 6 hours, and it is a symptoms-based bundle. Severe sepsis criteria all must be met within a 6-hour window. So the first thing we're going to need is suspicion of infection, documentation of that infection by a provider, so an MD, a PA, or an NP. We have to have SIRS criteria, and we have to have organ dysfunction for that. Our SIRS criteria is going to be a temp greater than 100.9 or less than 96.8. A heart rate greater than 90, a respiratory rate greater than 20, WBC greater than 12 or less than 4, or greater than 10% bands. Our organ dysfunction, we have cardiovascular, your systolic BP is less than or equal to 90, or a MAP less than or equal to 65. Respiratory is acute respiratory failure with new need for invasive or non-invasive ventilation. So we're looking at our BiPAP, CPAP, or intubation. Our metabolic is a lactic acid greater than 2.0. Renal is urine output less than or equal to 0.5 mLs per kilo per hour for 2 consecutive hours. Our creatinine greater than 2.0. Your hematologic is going to be your platelets less than 100,000, or an INR greater than 1.5, or a PTT greater than 60. And hepatic is going to be bilirubin greater than 2.0. Septic shock criteria is severe sepsis being present along with a lactic acid greater than or equal to 4, or persistent hypotension after the crystalloid fluids have been administered. Severe sepsis treatment, the first 3 hours you want to make sure that you get a lactic acid level collected, blood cultures, and broad spectrum antibiotics administered. Monotherapy or combination therapy. If we have combo therapy, both antibiotics have to be infusing, so they have to be started within the first 3 hours of presentation. If our lactic acid is greater than 2, we have to have a second lactic acid drawn to meet the measure. And that actually reflexes for us throughout the system. So if that lactic acid is 2.0 or greater, it'll reflex. And if the patient is hypotensive, so if they have a systolic BP less than or equal to 90, or a MAP less than or equal to 65, then we want to give them 30 mLs per kilo of crystalloid fluids. Septic shock treatment is initially the same treatment as severe sepsis, and they must have the 30 mLs per kilo of the fluid. And then within 6 hours, so after the fluids have concluded, and within 6 hours of time 0, we want to make sure that these patients are re-examined. And that includes a vital sign review, cardiopulmonary exam, a capillary refill evaluation, a peripheral pulse evaluation, and a skin exam. Here is some of our reasons for fallout for April of 2018. So we had fluids, lactic acid, and fluid reassessments were our top 3 that we fell out on. Lactic acid encompasses recognition of severe sepsis in a timely manner, septic shock in a timely manner, not drawing a lactic acid. That is the first thing that we look at with this measure. The fluids could be anything from patient not getting the appropriate amount of fluids or just not getting any fluids at all. And then the fluid reassessment is the provider examination within the 6-hour window. So we have a case scenario. On April 1st, 2018 at 08:42, a 25-year-old white male presented to the ED with complaints of shortness of breath. The patient has a history of type 1 diabetes and had an abscess of the left axilla during 2 days prior to presentation. The patient was then admitted at 10:53. At 09:02, the heart rate was 150 and respiratory rate was 28, so we have our surge criteria at 09:02. At 09:06, we have a diagnosis by the nurse practitioner of cellulitis of the left axilla and sepsis. And then at 09:20, we have a third surge criteria come back of a white count of 33.9. And then at 14:46, we have a lactic acid of 2.6. So this makes our time 0, 14:46. So that's when our clock actually starts ticking. So we've already have our lactate, so that component is met. At 09:35, they actually drew blood cultures before we had severe sepsis criteria. So we have our blood cultures completed. And at 10:06, the patient received cefepime 1 gram IV. And then at 18:45, we had the repeat lactate come back as 0.7. The patient had no hypotension. So this patient has passed the measure and received the appropriate treatment for severe sepsis criteria.
Thank you very much. Lacey, thank you for getting us started. If y'all have questions for Lacey, you can save them till the end, and we'll just go over any questions at the very end. What do I push? That's not it. That's not it. Lacey, what do I push to advance this slide?
It should be the left arrow button.
There you go. Oh. All right, I don't have any financial disclosures. I'm not going to be talking about off-label or investigational use of products. Thank you. We're going to talk about stewardship today. It's something I don't think we've ever really discussed. I think we've taken it for granted, and I think it's something that really permeates everything that we do, and I think that if we will pay a little more attention to it, that we're going to get even more benefit from really thinking about it and utilizing the principles of good stewardship in our everyday patient care. If you just look in the dictionary, stewardship is defined as the job of supervising or taking care of something, or the careful and responsible management of something entrusted to one's care. However, if you want to be a little more specific about antimicrobial stewardship, it's defined in a recent Clinical Infectious Diseases article. It's coordinated interventions that are designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regimen, which includes dosing, duration of therapy, and route of administration. And if you think about it, it sounds pretty simple, but it's really a pretty all-encompassing thing, and it's something that we've been working on more and more lately. So obviously the goals are as follows. They're to optimize patient outcomes, and they're also to minimize the unintended consequences of antimicrobial use, and we'll be talking more about that here in a minute. Lacey talked a little bit about one of the groups that's involved in stewardship, and that's the Sepsis Team. We also have other teams that are very dedicated to stewardship and all participate in their own way. There's the Antimicrobial Stewardship Committee itself, Pharmacy and Therapeutics Committee, and the Infection Control Committee, and each one participates in stewardship to a great degree, and they all work together, thankfully. The participants include the medical staff members, members from the pharmacy, from nursing, our infection control practitioners, members from the microbiology lab, and we also enjoy administrative support and couldn't do what we do without them. We have a lot of high priority items, one of which is looking at our antibiogram. We have a good idea of our antibiogram because we have micro here in-house. I'm in micro every day, at least once a day, if not twice. I keep tabs on the local flora and susceptibilities, and we also formally review our organisms and our susceptibilities annually. And we can also do it on an as-needed basis. That really doesn't come up much. We're looking at our own antibiogram. We look at Blunt. We look at St. Vincent St. Clair. We'll be doing Chilton soon, and we hope to be helping Birmingham with theirs before long. One of the other high priority items that we look at with antimicrobial stewardship is monitoring utilization of anti-infective agents. Particularly, we look closely at echinocandins. Our house echinocandin is Araxis. We look at carbapenems, specifically meropenem. And we also look at quinolones, Levaquin and Cipro. So that's just another of the many things that we look at as far as high priority items go. But the one I really want to focus on today and talk about today is Clostridium difficile infection. I've talked about it before, and it's a frequent topic. It's something we need to probably talk about more because it's an ongoing problem. We're going to talk some about the pathogen. We'll go over the new guidelines, and that's really, I think, the main reason to go ahead and do this today is because the new guidelines were published about 4 months ago or so. And we'll talk about specific treatment issues. Anybody want to make a guess about mortality due to C. diff? Before 2000, before the current problem, mortality overall with C. diff infection was about 1.5%. In the recent epidemic periods, and I gave you this so you can check me and make sure I'm not just making these things up. I really do have a bibliography. 7 to 17% mortality in the recent epidemic periods about the past 8 years or so. And that's even higher when you look at patients with severe infection, from 36 to 58%. So this is a significant issue from a standpoint of illness severity in particular. The organism is an anaerobic gram-positive rod. It produces spores and it produces toxins. The toxins are what make it virulent, make it pathogenic. The spores are what make it a real problem, and we're going to talk about spores a fair amount today. It's also the most frequently reported nosocomial pathogen in the United States, and that's as far back as a New England Journal article that I found from April of 2015, and it still holds true today. What would anybody think is the severity of a nosocomial Clostridium difficile infection on the cost of hospitalization? Any guess? Anybody want to venture some sort of estimate about how it might affect it?
250,000.
Well, that's an interesting number. Let's put it in context. Nosocomial C. diff more than quadruples the cost of hospitalizations. And this one article has said that annual expenditures are increased by approximately $1.5 billion in the U.S. due to hospital-acquired C. diff. So it's a significant amount of money. The organism colonizes the large intestine. It's an anaerobe. That's where it lives. It has to have a place to live. And, of course, we all know that affecting the normal flora makes an environmental niche for it, but it's just something that I think we need to stress a lot. There are two proteins that are responsible for the clinical illness. They're toxin A and toxin B. And these two toxins cause death of the colonocytes that line the colon membrane, resulting in loss of the intestinal barrier function and producing a neutrophilic colitis that's not just local, it's a systemic disease. Binary toxin is also produced. When you try to read about it, you'll find that experts argue about it somewhat. I did find one reference that says they have evidence that makes them believe that this suppresses host response locally, and it is associated epidemiologically with severe virulent C. diff infection. Transmission is by way of spores, and I think it's the spores that really make C. diff a problem. The spores are small. We can't see them. We can't test for them with any easily available test, and we actually have a hard time killing them. They're resistant to heat, to acid, to antibiotics. They're very plentiful in healthcare facilities. They're also found in the community and in the food supply in lower levels, but they are out there. And I really think it's important to discuss spores so that we can better understand the principles that underlie the precautions in C. diff, so that we can increase compliance with the recommendations and, I hope, to interrupt the spread of nosocomial C. diff infection. Compliance with C. diff, while I think here is reasonable, I think it's not perfect. I think we can do better. Would anybody like to come up with one barrier to compliance with personal protective equipment for healthcare workers that are assigned to C. diff patients? What's one reason somebody might give? And the answer is actually, when I asked a nurse in our CICU, why are people not serious enough about barrier precautions for C. diff? And the answer is it's not ugly enough. And so I'm going to try to make C. diff a little bit uglier for you. We've already talked some about how it's ugly from a financial standpoint because it increases cost. And if somebody can think of a good way to help me motivate colleagues to comply with isolation recommendations, let me know. I mean, we'd all be glad to hear your thoughts, but compliance is intermittent. I mean, I agree it's kind of a pain, but it's important. So to make C. diff infection ugly, we know it's associated with significant morbidity and mortality. We know it's costly. I guess another way to try to make it ugly would be to remind people that patients with C. diff infection shed large numbers of spores. They contaminate their skin, they contaminate clothing, they contaminate the bedding in their hospital room, as well as nearby environmental surfaces. And in one of the editorials that's accompanied some of the studies I found, the author said that a fecal veneer was created in the vicinity of the patient that's shedding C. diff spores. And that's maybe a term that we could use to emphasize just the ugliness of this illness. Healthcare workers can acquire spores on their hands, and they can transmit them to susceptible patients as well as themselves, incidentally. Spores can survive for months or even years on contaminated surfaces. They're very difficult to destroy. If the environment is heavily contaminated, such as the environment in the room of a patient with C. diff, the hands of healthcare workers are more likely to be positive for spores. And that's directly from an article in Clinical Infectious Diseases in June of 2010. So I think we need to remind every healthcare worker, nurses, dialysis nurses, respiratory therapy, everybody, gowns, gloves, hand washing before and after. I ran across a couple of things that have been shown to actually interrupt Clostridium difficile infection transmission during outbreaks. This is from a supplement in Clinical Infectious Diseases in 2008. Disinfection with bleach to minimize environmental contamination with spores, and also the use of effective barrier precautions during patient contact. So it all gets back to the spores. It's the spores that transmit disease. It's the spores we have to stop. Unfortunately, it's the spores that we can't see and we can't really test for. Are our infection control practitioners here? Oh, there you are. Hi. What cleaning agents are sporicidal? You think people know? This is an old list. You might have something new to add to it. Definitely sporicidal cleaning agents. The main one we have is bleach, chlorine-based. And way back when, we looked at high concentration vaporized hydrogen peroxide delivery systems. They're horribly expensive. They're very not well utilized just because they're somewhat problematic. Maybe there's potential for them at some point in the future. But I guess if you technically have to answer a question of what are sporicidal elements for C. diff, in addition to chlorine-based products, vaporized hydrogen peroxide. And if you go to the CDC website about C. diff infection, you'll also find some articles about applying hydrogen peroxide topically. It's not just the high concentration vapor, but the application of hydrogen peroxide definitely distinctly on surfaces, directly on surfaces, but the wait time, the time that you have to let it remain is just a bit prohibitive. And I don't know that that's ever going to be a real viable option for us in hospitals. So we know spores are spread by surfaces, touching surfaces that are contaminated. Has anybody ever really thought much about if they're aerosolized? And the answer is, of course, yes, they are. It's kind of hard to demonstrate it, but there's a study from Leeds, the United Kingdom, that was published in 2010. And they used research methods, and they did both air sampling and environmental surface sampling in wards and single rooms of patients that had Clostridium difficile infection. At that time, they still had patient wards. I guess we haven't had anything other than single occupancy rooms here for, 10 years or so now. But in 2010, there were still wards in England. And so they looked at air sampling and environmental surface sampling. When they sampled the air, they found that spores were recovered more often when patients had active diarrhea. They found that the spores from the air sampling did in fact match the isolates recovered from the patient, so it wasn't just something that was there in the environment, it was what the patients were shedding. And somewhat disturbingly, I think they found that spores were recovered from air more often during active times next to the patients. They said drink delivery. I don't think it was a bar on cart. I think it was just beverage delivery, lunch delivery, and visiting time. So whenever there was activity stirring up the environment, these spores were recovered from the air more frequently. And I think that's something we really need to think about when we think we can just dash into a room without putting on a gown and gloves. The spores were also recovered from environmental surfaces closest to the patients. I actually brought this article with me, and they never did really measure out how far you had to get from somebody before you could no longer recover spores from the air. It's something that's obviously difficult to do, and their methodology is in there. But, there's not a commercial test for this, and they went to a great deal of trouble to find the spores and then prove that that's what they were. Regardless, spores were recovered from surfaces closest to the patients and from areas that were frequently handled. The bed, the bedside table, the sink, and the trash can were specifically mentioned. At the end of the article, the author concluded that unless cleaning is done frequently around symptomatic patients with Clostridium difficile infection, that we're going to see reaccumulation of spores on surfaces via the air. So repeated cleaning is important. And also they emphasize that early patient isolation is necessary to prevent spread of spores and to interrupt nosocomial transmission, and I think that's true also. I've said it already, I'll just emphasize again that commercial tests for C. diff spores are not available. So in the absence of that, we focus on early isolation and identification of patients with C. diff, prompt treatment and appropriate treatment, consistent utilization of personal protective equipment, appropriate cleaning of the environment, and it's so obvious I didn't list it here, it's hand washing. And I've been asked to say hand washing about every other slide, so I'll just keep saying it. Let's go ahead and look at the new guidelines. It's the 2017 update. It was published, I think, in January of this year. Risk factors for C. diff infection, advancing age, duration of hospitalization, which is kind of frustrating for us because if you do a C. diff test after, 48, 72 hours? After day 4, you're going to own it as hospital onset. And obviously the other factor that's so important is administration of antibiotics. And we're going to talk about that a little bit more toward the end as well. Antibiotics suppress the normal bowel flora. This provides an environment for C. diff to flourish. The risk of C. diff infection increases during the antimicrobial therapy and also in the 3-month period following the ending of administration of antimicrobial therapy. There's a long-lasting disruption of normal bowel flora. And I've seen some of these authors that have even said 6 months following normal flora is interrupted. The guidelines give us standardized case definitions, healthcare facility onset, community onset, but healthcare facility associated. And Lindsay, you can correct me if I'm wrong, but this is just somebody that's spent the night in some sort of a healthcare facility in the previous 3 months. And then the last is community onset. We're obviously more concerned with hospital onset or hospital onset healthcare facility associated, but we also certainly do run across community onset patients. This is a good question. What patients should be tested for Clostridium difficile infection? They should have unexplained and new onset of diarrhea, which is at least 3 unformed stools in 24 hours. Please do not test patients within 48 hours of laxative administration. It's an ongoing issue. As pharmacy knows in particular. Do not perform repeat testing within 7 days during the same episode of diarrhea. Don't test stool from asymptomatic patients unless you're doing epidemiologic research. The repeat testing idea has been difficult to convince people of. Isolation measures, private room with a dedicated toilet. I think we all take that for granted, but they're in the guidelines. Healthcare workers must wear gloves and gowns upon entry into the patient room and during patient care. Since we don't have a direct measure of where these spores might or might not travel by air, probably our best defined point of where to put on personal protective equipment is the doorway to the hospital room of the patient. So before you walk in the door, you put on your gown and gloves. And you take them off before you walk back out and wash your hands. This is also included in the guidelines, and we also emphasize this as often as we can. Patients with suspected C. diff infection are placed on preemptive precaution pending the results, which take about 45 minutes or so in our lab. This is where a fair amount of arguing comes into play. Precautions are recommended to be continued until discharge if the rates of C. diff infection in your facility are high. If the rates are low enough, and nobody ever defines low enough, they just say if you personally think they're low enough, then precaution should be continued for at least 48 hours after the resolution of diarrhea. However, then they go on in the guidelines themselves, they go on to say that shedding of C. diff spores is particularly high among patients who have been recently treated for C. diff, even after resolution of diarrhea. And so I've put my comment in here that I personally recommend continued isolation until discharge. We'll look at special circumstances on a case-by-case basis, but I think overall, and I think we've been glad that we've stuck to this, that patients are maintained on isolation precautions until they leave. Hand hygiene, before and after patient contact, soap and water. This has increased efficacy of removing spores from the hands of healthcare workers and also from patients. And we need to encourage our patients with C. diff to wash their hands, to shower, try to reduce the burden of spores on their skin. And the authors did mention that showering is more effective than a bed bath. The guidelines tell us to use disposable equipment when we can, but if not, we need to make sure that reusable equipment is thoroughly cleaned and disinfected. We also incorporate methods of measuring the effectiveness of our cleaning to ensure the quality, just like we ensure quality in every other aspect of what we do, we have to ensure the quality of cleaning, and what we use locally is an ATP bioluminescence test. And that's done regularly and reported at every infection control meeting. The guidelines also recommend implementing an antibiotic stewardship program to reduce the risk of C. diff infection and to restrict the use of quinolones, clindamycin, and cephalosporins, and they will give an out on the cephalosporins and say that they don't need to be restricted in the area of surgical prophylaxis, but that we need to look specifically at quinolones, clindamycin, and non-surgical prophylaxis cephalosporin use to help curb C. diff numbers. Proton pump inhibitor restriction is something that we've done well at recently. We can get you a copy of the recent Ascension bulletin if you want, showing how we've recently had a very good reduction in our proton pump inhibitor use. There definitely is an epidemiologic association between PPI use and C. diff infection. The guidelines recommend that unnecessary proton pump inhibitor administration should be discontinued. And they go as far as to say that continuous use of PPIs is associated with a 50% increased risk for recurrent C. diff. And here's my slide on the, our local reduction in PPI administration. I think the final number was we've reduced it by 76% over the past 6 months. And I think we can take that success and put it towards stewardship in other areas as well. The 2017 guidelines mention probiotics. They say that there's insufficient data and that it's a prescriber's choice. We tried to help answer this question. It was difficult. Other ancillary treatment strategies, and the one that I just cannot emphasize often enough, stop the inciting antibiotic agent as soon as possible. I mean, the things that are done for C. diff patients, if somebody's septic with a pathogen, if they've got pneumonia and are in the unit on the ventilator, you know, that's one thing. But there are so many people that will get put on treatment for C. diff, and then somebody will check a urine culture for reasons I can't quite fathom, and they'll be given more antibiotics. That is counterproductive. So discontinuing other therapy is very important. The guidelines have changed the treatment paradigm. We're going directly to oral vancomycin. Oral flagyl is not effective enough anymore. There are too many treatment failures, too many relapses, too many recurrent episodes after. If a patient has ileus, you can give vancomycin orally in the high dose to 500 Q6. You can also give it rectally, 500 milligrams and 100 mLs of saline every 6 hours. If somebody is that sick, they should probably go ahead and receive intravenous flagyl as well. The guidelines don't say a lot about where exactly to put FMT or fecal microbiota transplant, except to say that it's recommended for patients with multiple recurrences that have failed appropriate treatments. Some authors are saying that FMT should be used earlier and that multiple doses should be considered. The efficacy on recurrence has been reported to range from 70 to 100%. I think it probably settles out at about 80 or 85%. And it's something that is available here and that I've been real impressed with. There's an article in Clinical Infectious Diseases from this past March on early FMT. It's a 3-year study. All patients were in the infectious disease department. It's in Marseille in France, and they had a nice little cohort of patients in their ID department in their hospital. They used fresh stools during their first half of the study, and about midway through they transitioned to frozen FMT product. They included 111 patients. The median age was 82 years, and they either got FMT or antibiotic treatment. Overall, the mortality was 24%. It was lower in the FMT group, only 12%. It was 42% in the antibiotic treatment group. There was no difference between the use of fresh or frozen FMT. They were equally efficacious. So the author's recommendations from that study were that early FMT should be proposed as first-line treatment, particularly for severe C. diff infection. Also in a recent publication, establishing a fecal microbiota transplant service for the treatment of C. diff infection. I don't know that we've formally done that as such, but we in effect have a protocol that we're using that's working pretty well. FMT is in fact the most successful treatment for recurrent disease due to C. diff. Patients should be looked at for FMT based on the number of recurrences, the severity of infection, and particularly disease refractory to antimicrobial therapy. This is one of the few things that doesn't have much in the way of contraindications. Would anybody like to propose an absolute contraindication for FMT? It's perforation. GI perforation, no FMT. Toxic megacolon is a contraindication to FMT by colonoscopy, but Dr. Lopez has, and I think very rightfully so, chosen to go the upper route and to administer the FMT product in the mid portion of the duodenum. Oh, and by the way, the patients we've had here with toxic megacolon have gotten a surgical consult pretty quickly, so I think by the time they get that sick that FMT is probably not appropriate. If you read the studies, people will go on and on about how do you prep the bowel before FMT, a lot of other things that are interesting, probably pretty important, but for duodenally administered FMT, you don't have to do a bowel lavage. So I think that's also another interesting aspect of considering where to administer this product. Establishing the frozen stool bank seems to be the best way to do it. We've got frozen product available. Dr. Lopez has been our physician champion. He's been just a real amazing resource, and I appreciate all his help. Before I go to conclusions, I'm going to mention one other article that came out since I gave my slides to Lisa. And this is from Emory. I always like looking at local things. It just makes it seem a little more real somehow. This is an article from June 1st, Clinical Infectious Diseases. It's called durability and long-term clinical outcomes of FMT in patients with recurrent C. diff. And basically, they looked at patients, it was between July 2012 and December 2016. It was a post-FMT survey, and it was done at a median of 22 months follow-up after the patient's last dose of FMT. There were 137 patients. 82% didn't have a recurrence, so that's a pretty impressive rate. 18% did have recurrent C. diff following FMT, and of those, it was the patients that had ongoing antimicrobial exposure after FMT that were more likely to relapse. So really being stingy with antibiotics, I think, is important. The other thing they looked at that is something I think we're going to start seeing in the literature more and more, because we look at it more and more every day, they did a patient satisfaction survey at the end of it, or as part of this post-FMT study. Anybody want to guess how many patients said they would choose FMT over antibiotics if they had recurrent disease? 70%. It was high. They liked it. It worked. It was easy. They got their treatment. The folks we've had, I think it shortens hospital stay. I think they get out quicker. It's a good study. I'll be glad to give you the bibliography if you want it. In conclusion, stewardship is a team activity. It involves everybody working together. The principles can be applied to every aspect of patient care. C. diff is serious, it's ugly, it requires careful adherence to our treatment and isolation recommendations. And I think we always need to remember to utilize our local resources. Pick up the phone and call the pharmacy, call the infection control practitioners, I've got them on speed dial. Call the micro lab, they're ready to help, they're smart, they know what they're doing, they do a great job, I depend on them. And call your colleagues. If somebody needs FMT or if you have a question about it, Dr. Lopez has been great. Call me. Talk to each other. I think the fact that we don't just pick up the phone and call sooner rather than later is probably a mistake that we need to correct. You have questions for me? Do you have questions for Lacey? Yes? I'm sorry? The mechanism of action of FMT, it squeezes out the C. diff. It is destroying that environmental niche that C. diff has snuck into. It's repopulating the gut with protective flora. And it's literally getting rid of that niche in the colon environment, and C. diff goes away. Sometimes FMT needs to be given more than once, but it does seem to work better than antibiotics, but that's the mechanism. Yes?
It works, so we consult Dr. the GI, any of the GI, or just Dr. Lopez, and where are the FMT specimens stored?
The specimens are stored in the blood bank because we have to have a refrigerator that's got 24-hour surveillance, quality control, etc. It's in the blood bank. Actually, the way I do it, I keep Gail Lopez on my speed dial, and I just text her when I want them to look at a patient for FMT. Gail, I hope it's okay for me to say that. It's too late. But it's worked out great, and they've always seen our folks right away, and barring anything unforeseen, they usually get FMT the next day. Other questions? Yes?
How much do you think it's costing our institution an additional cost for overall in the C. diff cases? Do you know?
Just based on what I've read, I mean, it seems to consistently quadruple cost of care. So whatever the cost for patient X would be, I think if they get C. diff during their hospitalization, 4 times X is probably going to be the most reasonable answer.
How much do you estimate that,
Yes, sir.
how much do do you estimate that each patient costs for their treatment while they're in the hospital?
Depends on what their treatment is, and I don't know, and I'm not sure if there's a way to collect that data. I'll have to think about that. I think that going beyond a statement as broad as quadrupling the cost of care, I think it might be harder to drill it down any closer or any more specifically. Yes, Laura?
How small are the spores?
I looked that up earlier today because I just knew somebody was going to ask, and I wanted to be able to give
My question
the
is,
right answer.
can a filter catch it? Is what I want to know.
I don't know that we've got the capability to filter air through something that would catch a 1 micron spore. It's too small. They're about 1 micron. When I did look this up, the answer I found was pretty interesting. They vary in size, but overall an average is about 1 micron diameter. It's small. They even went into how long, if it's aerosolized, how long it might take to settle out. And it could be in the air from 7 to 28 hours, they said, before it finally lands on a surface. And I think if we could see the spores, we'd probably be horrified. And that's why I've tried to spend a little more time on that than usual. I think it's part of it that we don't think about enough because we can't see them. And I think you're right. I think that filtering them out is at least a place to start thinking about it. But what we need to do is we need to bust them up with bleach. And that really is where we are now, and I think for the foreseeable future. Other questions? All right, thank you very much.